Would you like me to stay here, or do you want me to? Okay.
Jean's not there.
Okay.
Have you thought about using autografts like Philippe?
Yes. Yeah, we've thought about using autografts. However, I do like the size and the bulk of the Achilles tendon allograft because you can get a very, very wide insertion onto the greater tuberosity, and then you can also have that for incorporation to any of the other rotator cuff that may be repairable to the allograft. But autograft is certainly a great option, and Dr. Valenti has published good results with it.
Any question?
Yeah.
Please.
Yeah, my name is Adam. Sorry.
No, you ask it first. Yeah,
Okay.
please.
Thank you for the lecture. It's an interesting subject, using trapezius instead of latissimus dorsi. But I noticed that you only compare the direction of the muscle,
Yes.
but you didn't really compare the outcome or the, I don't know what kind of communication I expect with lower trapezius transfer, especially using a graft.
Yes.
Achilles graft. So can you
There's
just
there's
enlighten us
no published studies comparing latissimus dorsi with lower trapezius. We're currently doing a multi-center study in the United States comparing lower trapezius with latissimus dorsi tendon transfers and superior capsular reconstructions. So you have a very good point. We really don't know the ultimate outcomes comparing these techniques. I'm not implying that lower trapezius is necessarily better than the two because we just don't know the clinical results. It's just a different vector of pull and thus another option as compared to the latissimus dorsi.
Thank you.
Another question, please.
Do you know of any study specifically studying the morbidity generated by the transfer regarding lower trapezius or latissimus dorsi?
This is all we have regarding lower trapezius and the morbidity associated with it. Most commonly seroma, hematoma, but no studies have found significant scapular winging or dyskinesia. So overall, it is low morbidity. It is possible to damage the spinal accessory nerve, so that's something that has to be very carefully harvested so as to not damage the spinal accessory nerve.
But nothing about the function.
Function?
The function of the muscle. It's not affected?
No, because you're still preserving, you mean of the trapezius?
Either one. Trapezius or latissimus dorsi, because those tendons had a function.
Yes, well,
right?
Yeah, certainly. But with the with the trapezius, you're preserving the middle and upper trapezius. Therefore, you're not having any significant impact on the rest of the tendon.
But is that studied? That's studied clinically?
Yes, according to the results from the studies that I just presented.
Okay, I'll check then.
Yeah.
Thank you.
Yeah.
So thank you. Another question, please. Yeah.
You're referring.
You can ask here.
Yeah.
No problem.
Thank you. You're referring results from patients with the neurological injury, a brachial plexus injury, and you are also referring results from chronic rotator cuff tears, massive tears. You think it's appropriate to compare these two quite different patient groups, or could you comment on that?
Well, I'm not comparing them directly. I'm presenting what has been presented in the literature, but you're right, there are very different sets of patient populations. In the first study, the initial reported results in 2012 and 2014, some of those patients did have other tendon transfers in addition to the lower trapezius. I'm merely presenting the history and the early results presented. It has yet to be determined as far as the ultimate outcomes for patients with irreparable cuff tears. We only have 2 studies that present that, one from 2016, one from 2018. So this is still in its infancy.
If you have a patient with already scapular dyskinesis, this patient has a massive tear, he has already scapular dyskinesis, and we know sometimes scapular dyskinesis may be the cause or the result, but we don't know yet. Would you go for a lower trapezius, or you would decide for another tendon transfer?
That's a good question. I mean, if the patient already has scapular dyskinesia, then I would err on the side of not doing a lower trapezius so as to prevent any further destabilization of the scapula.
Please, question, yes, there.
I would like just to comment that also latissimus dorsi transfer, if you detach it from the scapula, it produces dyskinesia. We had a discussion with the girls from Eucerus team, and they said that if you detach it from the scapula, you surely have dyskinesia also with latissimus dorsi transfer.
As far as we know, I mean, as far as the lower trapezius, I can comment on the lower trapezius. There hasn't been any significant scapular dyskinesia reported in the literature, and I personally haven't experienced that. So I think further investigation is warranted as far as if EMG studies that can be performed after lower trapezius to ensure that there's no significant scapular dyskinesia afterwards.
Any other question for this nice presentation? For the people who do transfers, they like maybe the lower trapezius because they keep latissimus dorsi for another transfer. So because you have patients sometimes with, but it's okay. For the people who is doing, hand surgery, when you transfer muscle, you lose one grade, yeah? And when you do an augmentation with the graft, as you do, you lose 2 grades. So there is a little bit concern about this regarding tendon transfers generally.
Good point.
But I think it's a very nice and clever technique, my opinion. Okay, there is a light lunch. Time now is over. Thank you very much for the session.